Greetings to judges and audience. The title of our poster is Efficiency and Accuracy of Gugging Swallowing Screening, GUS versus FEES, Fiberoptic Endoscopic Evaluation of Swallowing, to determine the texture for food and liquid for individuals with oropharyngeal dysphagia. The authors of this poster are myself, TAMANNA BOOBNA, and Dr. Vani K. Gupta. The aim of our study was to replicate the validity of GUS and then compare it with FEES in a cohort of patients who had acute stroke. And there are three ways to actually denote intervention studies, but we wanted to go for an efficiency based study because our target was to come up with something which is economic, affordable, and practically applicable in every situation. So efficiency is about doing things in the most economic way, whether it's in terms of time, energy, money, availability of resources. And as we know, dysphagia affects around 22 to 65% of patients with neurological condition, and the gugging swallowing screening, that is GUS, is a tool to screen aspiration risk for semi-solid, liquid, and solid textures in acute stroke patients. So the need of the study was basically, we are aware that there is a large variety of bedside tests that is used to detect dysphagia, but it's unknown which has the best psychrometric property and the feasibility to use in comparison with instrumental evaluation. So we wanted an economic yet standardized tool to determine the safest texture for individuals with oropharyngeal dysphagia, which is primarily the need of the hour. And we had 15 acute stroke patients with mild to moderate to severe National Institute of Health Stroke Severity Scale, and we assessed them prospectively using the GUS, which is the screening tool to determine the texture of food and liquid that is safest, that has the minimal risk of aspiration, and then we correlated the findings with an instrumental evaluation, which is FEES. So as a result, we found out that the texture modification determined by GUS were in accordance with that of FEES across all the patient, meaning if my instrumental evaluation said that the patient was safe to go for semi-solid food but was aspirating on liquid, the same thing was verified with GUS as well. So this explains the potential efficiency of GUS as a safe tool to determine aspiration risk as well as the texture modification for patients with dysphagia in the absence or in accordance with that of FEES. We have all seen in the hospital setup where FEES is available, lot of times affordability is a big question mark for the patient. Lot of times the patient does not want to go for expensive test, or he is unable to have the means for the same. So we really wanted to have something which was potent and valid, which could actually screen the patient and tell us, okay, he is safe on this texture, or he's not okay with solids, or he's okay with solids. And as we all know that liquids are generally the first step in almost every reported dysphagia screening, and also the contradictory fact that the majority of acute stroke patients, according to clinical observation, had more difficulty swallowing liquids than semi-solid texture. But GUS is a very step-by-step assessment approach that minimizes the danger of aspiration throughout the test. It also allows for graded rating starting with non-fluid textures. Plus, added advantages, it's very cost effective, it is less painful for the patient, it will allow him to continue eating normally without any significant risk of aspiration. And this innovative tool will permit nutritional advice, it will measure the severity of dysphagia, and it will allow for a graded assessment of the patient's swallowing ability. So maybe the patient is not able to have liquids, but he will be able to have any other safe texture for him. And in the absence of instrumental evaluation, or even to bolster up the finding of FEES, this could be a very potent screening tool. In our study, the texture of food that permits maximum swallow safety through GUS was corresponding to the finding of FEES across all 15 patients, and this could probably be attributed to the graded approach of GUS that focuses on solid as well as semi-solid textures as opposed to only liquids. Although we are well aware that we had a small sample size and there was heterogeneity in the stroke severity, to conclude, I would like to say that with the increasing incidences of dysphagia, it is very important to have a reliable bedside tool that is economic and that assists in better intervention with regard to texture modification and recommendation, And as swallow therapy is extremely volatile, the possibility of carrying out instrumental evaluation like fees on a regular basis is not really always possible. So the need of the hour is to have a standardized, reliable bedside tool that assists and augments the same. And GUS is a great tool to bolster up the finding of fees. Thank you so much.